got one more talk. It's a pre-recorded talk by Dr. Morshed, who I already introduced earlier. And he's going to round off this session by telling us about building sustainable academic partnerships, the IGOT experience. So, Irlin, can you please run that?
Hello, my name is Saam Morshed. I work at UC San Francisco, and I'm going to be speaking about building sustainable partnerships in global orthopedics. I sit on the executive board for IGOT, the organization that I'm going to be describing in this presentation, but I have no other relevant financial disclosures. We're going to talk a little bit about burden of disease here, current programs that we're running that might serve as a model for partnering with institutions in the low and middle income countries, and some lessons learned along the way. It should come as no surprise to anybody here that the burden of musculoskeletal disease is massive globally, and as of today, largely unmet. The mortality rates of injuries is higher than HIV, malaria, and TB combined in low and middle income countries, and 95% of deaths caused by injuries occur in low and middle income countries. This might come as a surprise to anybody who's never been out on the roads in an environment like this and seen the perilous state of road traffic in most of the world, and very quickly you realize that this should really be obvious to all of us. It's important to know that those that die from injuries are just sitting at the tip of an iceberg, and there are about 20 to 50 million left disabled for every 1 million or so deaths due to road traffic safety injuries. And this rate is 2 to 5 times higher in low and middle income countries as it is in high income countries. This enormous and previously undocumented burden exists across the musculoskeletal spectrum here, whether we're talking about pediatric orthopedics, arthritis, hand surgery, spine surgery, and even largely elective subspecialties like sports medicine. There's a huge shortage of surgeon workforce. For example, in Ghana, you have about 1 orthopedic surgeon per million, whereas we have 75 orthopods per million in the United States. And the dearth of trainees is even more impressive. Surely then a problem so grave and costly as injury or musculoskeletal disease in general would deserve a major cut of the global health funding pie. Alas, no. Funding directed to injury research prevention and treatment accounts for only a fraction of a percent of global health funding. So the world has a problem of unmet burden, major barriers to access to modern surgical care, and funding to make it all better. It's just not forthcoming. Clearly, there are so many levels where interventions are required, addressing root causes like poverty and road traffic infrastructure notwithstanding. But what can we do as orthopedic surgeons? The most accessible level for most of us is tertiary prevention or improved surgery and treatments for these conditions once they've been diagnosed. This noble motivation that most of us share has led to generations of surgeons and healthcare workers to participate in medical missions. But most of such programs have limited follow-up and lack of sustainability. Rather than medical missions or even volunteerism, we have advocated a more lasting approach based on academic longitudinal partnerships. Starting in 2006, a number of faculty members at UCSF set up a nonprofit departmental initiative that emphasized academic partnering. Currently, we have partnered with institutions in Central and South America, Africa, and Asia. We have an executive team shown here, as well as 1 full-time staff member, and rely on many of our partners within the department to participate in our outreach and educational and research initiatives. We have an advisory council that advises our board. And we've founded our organization based on 3 pillars of education, research, and leadership. The program started with a global resident elective, and currently this resides within our 4th year of training of our orthopedic surgery program. Many accounts have been written by our residents, as well as our partnering institutions, as to the importance of this experience along their residency training journey. And early on, we were able to document the impact lifelong on our trainees in terms of how they pursued their careers and continued to give back in terms of volunteerism. Still, an important perspective was neglected, and that was that of our hosts. It would take 10 years and Sanjeev Sabharwal joining our ranks to pose these questions. We took advantage of a recently initiated consortium called COACT, which I'll discuss again, to survey programs directors presently involved sending residents abroad international training rotations in LMIC, as well as those who host their trainees. 26 program directors and 136 North American residents responded. The first finding that I want to draw your attention to is the discordance in motivations in North American trainees seeking surgical skills and our lower middle income countries, partners desiring knowledge transfer and research collaboration. We then undertook a systematic review of the literature to identify many studies that try to establish best practices in running these sorts of educational exchange programs. And we've summarized these using a technique called meta-ethnography. The take-home points were that for high-income residents rotating in LMIC, residents should receive site-specific preparation prior to departure, remain in country long enough to develop site-specific skills as well as relationships, and exercise flexibility and a cultural humility mindset. We've endeavored to learn from these findings as we've improved our own exchange efforts, which now include funded opportunities for trainees from partnering LMIC institutions to come to UCSF for observerships. We conduct in-country training courses designed based on the express needs of our partners. These are a very efficient way of delivering this information and skill training in an environment that's much more efficient than bringing trainees halfway across the world to San Francisco. Focus has been on open fracture management techniques to date, using simple, locally available hardware and emphasizing useful soft tissue techniques for wound and bone coverage that do not require micro. We have a wonderful online portal that we've built out over the last couple of years with high quality didactic and surgical videos that is frequently subscribed through to globally. Let's talk about our research program, which is comprised of active ongoing research programs and training opportunities for our partners as well as our own trainees. Our research programs include prospective trials currently run in Africa and Latin America that now generate 20 to 30 publications per year with funding from professional societies and federal funding agencies. These programs are facilitated and greatly enriched by our brilliant medical student fellows that take a year off if they're selected through a competitive process, and are profoundly talented resources that support the efforts of our global research initiative. How do we keep this all running if we're not in country 12 months per year? Well, we don't. Our partners do. The building up of research capacity at sites like Muhimbili in Tanzania has been tremendously gratifying. Our partners present locally and internationally, they lead author manuscripts, and importantly, these endeavors lead to their professional and academic advancement. I told you about Tanzania, but it's important to highlight the incredible work that Colleen Sabatini is doing in Uganda and Ted McLeod has done in Latin America. Many ways to count both the direct and indirect research accomplishments of this program. More important are the studies and manuscripts completed by our partners, independent of our investigator and those of their own trainees. As you can imagine, these sorts of endeavors that involve educational exchange and research contracting also requires specific agreements depending on whether work is funded or not. And this process can be similarly circuitous, given that many finance offices are not prepared to do the post-award work or invoice research services. We still struggle with this after a decade or more, but more and more institutions are developing the financial and legal sophistication to handle these processes. And this is something that we're happy to share with you if you're interested. And speaking of funding, getting a global orthopedic program off the ground will seem like a labor of love and be incredibly rewarding, but departmental support, especially early on, is absolutely key. We have had to be creative and gone into periods of austerity to weather dry spells in funding. I recommend trying to use the usual professional societies and foundations and federal funding agencies and be persistent. The third pillar of IGOT is linked closely with our research and educational pillars, using those spaces for identifying local leaders who may benefit from further support and mentoring. An example of such a program is the leadership program that Ted McLeod has developed for the Actor Network that is delivered now broadly across Central and South America. Recognizing that programs like ours that have been at it for all this time can really help other programs get started, we set out to create a hub for North American orthopedic programs interested in sharing best practices, educational programs, research projects, and looking to collaborate. We have discussed, or we have performed joint projects such as the host country survey that I discussed earlier, and I encourage you to visit our website and join with us. Let me wind out this talk with a summary of elements that we have found vital to our own efforts. Successful partnership requires a foundation of motivated and able individuals and institutions with a strong bidirectional commitment and solid communication. Institutional support is vital to seeding this partnership on both sides, beyond which they can become self-sustaining efforts. As I mentioned before, successful partnership relying on and tending to the health of the relationship and based on what we've found in the literature and what has been reinforced by our own experience in developing a culture of humility and commitment to a reciprocal relationship. Educational programs should be bidirectional and focused on needs. Research programs should be derived and ultimately driven by hosts and their questions and priorities. And finally, identify and support partners in their professional growth, as this is the future. I thank you very much for your attention and hope that we'll have a fruitful discussion.